This is On Air with EUFOREA.
Hello, everybody. I am Wytske Fokkens from the Amsterdam University Medical Centers in the Netherlands. And it's a great pleasure to speak to Michael Wechsler from Denver, US. Michael, maybe you shortly introduce yourself and then I have a question.
Sure. It's great to be here with you as well. I'm Michael Wechsler. I'm professor of medicine. I'm director of the National Jewish Cohen Family Asthma Institute, and I do clinical trials in asthma. I see patients with asthma, and I lecture about asthma.
Well, let's do the lecturing now. And what I really would like to hear is your view on, we live in such an interesting period with all the new treatment options. What is your view on the future of asthma care?
We're so lucky to have a lot of therapeutic options for our patients with asthma. I often say it's a good time to have bad asthma. But we have so many new therapies that biologics that target interleukin 5, interleukin 4 and 13, IgE, and most recently TSLP. And so that's really, really exciting. But unfortunately, while these therapies work very well, there's still a number of therapies that don't address all of our patients' needs. And so we need probably better therapies that work differently in a subset of patients. We need therapies that work better overall, and probably we need therapies that might have certain dosing advantages. So as I look into the future, I see, first of all, therapies that will be given every 4 or 6 months. I think that's one innovation that I think will be coming. That'll make it easier for patients, and it'll also improve adherence. Also, I think that we are going to identify novel pathways and novel targets. There are already some that are being evaluated and studied, new biomarkers that are potentially beneficial in terms of identifying subsets of patients. And then I think new strategies as well. There are some dietary supplements. There are some antimicrobial therapies. There are some novel cytokine pathways that are being studied. Things like IL-6, IL-33, IL-23, and others, IL-17, that may benefit a subset of our patients that aren't responding to current therapies.
Well, that's very interesting. Can you give an estimate? Because, if you say from all these severe asthma patients that you see, what percentage is now sort of happy or controlled with the new biologics that we got in, say, the last 5 years? And what percentage still is uncontrolled?
So it really depends on what our goals are for asthma management. Getting patients in control is an important goal, and it's estimated that about 2/3 of patients can get into control if they're given appropriate biologic therapy. But more recently, we're striving for more than just control. We're striving for remission in asthma, which, the definition of remission is evolving, but it includes having good asthma control, being on no oral corticosteroids, having no exacerbations, really having minimal interference with daily activities, but not just having it for a short period of time that would suggest control, but having it for a sustained period of time, for at least a year. And so there's a difference between response and improvement and in terms of remission. Those are two separate concepts. You can have a person who will go from 4 exacerbations to 2 exacerbations in a year, and that person is a responder, but that person isn't necessarily in remission because they're still having exacerbations. So that's our latest goal. We can achieve that in anywhere from 20 to 40% of patients. So I think that should be our next goal, is trying to achieve remission in a larger subset of patients. And maybe we can do that with new therapies. Maybe we can do that with better biomarkers. Maybe we can do that with other novel strategies. But we also still need to keep in mind that we need to address comorbidities and adherence, as well as environmental factors for all of our patients with severe asthma.
Okay, and then my last question, of course, what we really want is cure. What about cure?
So the distinction between cure or disease modification, if you will, and remission is that remission implies gaining good control over a period of time, but on a therapy. Cure and or disease modification really implies that you are able to get a patient off of therapy, that basically they no longer have asthma. That's what we're striving for ultimately. I don't think that we have many patients who can achieve that goal. There, we're trying to reverse the underlying disease. So when we compare it to a disease like, let's say, lung cancer, if someone has a lung nodule, you take it out, they're effectively cured from that disease. But in patients with asthma, there still is this underlying inflammatory process that needs to be controlled by current therapies, by the inhaled corticosteroids, by the biologics that patients are currently taking. One of our goals would be to try to taper patients off of all therapies and have a sustained remission. We're not quite there yet. I think we need longer acting therapies that might benefit our patients.
Well, thank you very much. That's really very interesting and a lot to dream of for the next future and but also already for the coming years, I hope.
That's what we're working on, and I hope that we can achieve remission, disease modification, and cure for our patients with asthma.
Thanks. Wonderful. Thank you very much.
Pleasure.
This was brought to you by EUFOREA, inspiring the future of respiratory care. This podcast was supported by an unrestricted educational grant from Sanofi Regeneron.